Hello and welcome to our third and final Alumni Hour event for 2021. This is the series where we get to have in-depth conversations with some of the most extraordinary alumni of the Faculty of Medicine, Dentistry and Health Sciences at the University of Melbourne. My name is Angela Lavoipierre. I'm a journalist and presenter at the ABC, and it's been my absolute privilege to host this series for the last 2 years. Before we begin, I'd like to acknowledge and pay my respects to the Gadigal people of the Eora Nation. They're the traditional owners of the land that I'm on today. I also pay my respects to the traditional owners of the many lands we're all on, to their elders past, present and emerging. Today, we are incredibly lucky to be talking to the University of Melbourne alum, Dr. Michelle Blanchard. Michelle is Special Advisor at the National Mental Health Commission, leading the development of a national strategy to reduce stigma and discrimination towards people who experience mental ill health and their families, friends, and support people. There will be a little bit of time at the end of this session for audience questions. So if you think of something that you do want to ask along the way, don't be shy, just enter it in the Q&A function on Zoom, which we're all only too familiar with by this point, and we will get to as many as possible at the end. First, a little bit about our guest. Michelle completed a Bachelor of Arts with honours at University of Melbourne in 2003 with majors in psychology and politics. And she's come full circle in her role with the National Mental Health Commission. She's brought to bear her expertise in psychology and in mental health, but it's been quite a long path. So Michelle completed her PhD in youth mental health in the Faculty of Medicine, Dentistry and Health Sciences in 2011. She's held senior roles at the Butterfly Foundation for Eating Disorders and the Young and Well Cooperative Research Centre. And prior to joining the Commission, Michelle was Deputy CEO at SANE Australia and the founding director of SANE's Anne Deveson Research Centre, which works with people with complex mental health needs to bring about social change. Michelle is also an honorary senior fellow at the Melbourne School of Psychological Sciences at the University of Melbourne, which happens to be celebrating its 75th anniversary this year, so happy birthday. Quite the CV. Welcome, Michelle. Thank you so much for making the time to join us.
Thanks so much, Anne. It's really great to be here.
Yeah, it's a pleasure to have you. I've got a long list of questions to get through, so we'll get started and try to reach as many as we can. We have, of course, introduced you as the Special Advisor at the National Mental Health Commission. But before we get to that, I want to start at the beginning, if possible, because there's probably never been a greater awareness, I don't think anyway, of certain kinds of mental ill health, things like anxiety, stress, depression. We all feel better informed than we ever have been, but it's not the whole picture. I was hoping you could start by maybe giving us a bit of a broader definition to work with, I suppose the limits of what we mean when we talk about mental health and mental ill health.
Yeah, it's a really great place to start. And the definition of mental health that I really love is the one that the World Health Organization talks about. And they talk about mental health really being a state of well-being where an individual can realize their own abilities, can cope with the stresses of life, can contribute productively to their community. And so for me, I'm always really surprised when the conversation about mental health focuses solely on our experiences of distress or mental health problems, because mental health is actually this really positive concept. It's about our well-being. It's about the way that we approach our lives. But sometimes we have periods when our mental health can be challenged. So that might be a period of distress. It might be a response to something traumatic that's happened in our lives. And for some people, it might also be a problem in terms of how they might be feeling, thinking, or behaving. And that's really what we talk about in terms of mental ill health. So that's the kind of flip side, I guess, of the concept of mental health.
I love that definition because it's so much more inclusive. It makes it not about a subset of society, but it's really about all of us.
Absolutely.
What is it that got you interested in this area to begin with? How did you start down this path?
Yeah, Something I've thought about a lot, because sometimes I feel like I just fell into doing this work, but really what got me most interested in working in this area was my own personal experience. So when I was studying in my final year of school, I had ambitions to be a medical doctor. I desperately wanted to be a doctor, to study medicine at university, and it wasn't a great year. So I experienced quite a few challenges along the way, and didn't feel that great about myself, and didn't end up getting into the course that I wanted to at university. But along the way, made a decision to move from Perth to Melbourne to study at the University of Melbourne. And around that time, I heard an ad on the radio. It was on Triple J, actually, for reachout.com, which was just getting set up in Australia at that point. So this is at the end of the 90s. It was established as Australia's first website to help young people with their mental health and wellbeing. And so there was something about hearing about Reach Out on the radio and really connecting with some of the ideas of going through a tough time that attracted me to go and visit the site. And ultimately, when I was in my first year studying at the University of Melbourne, I started volunteering with Reach Out. And it was through volunteering with Reach Out that I started to make sense of my own experience of mental ill health. I met some incredible people, many of whom have gone on to be mentors and colleagues. And I think it was that really kind of sparked this interest. But as I kind of went along my journey, I experienced other periods of mental ill health as well. And in particular, in my mid-20s, I was living with an eating disorder. And at the time, I was working in the mental health sector. So I'd moved from kind of volunteering to working full time, but somehow still didn't feel like I could share that experience with the people around me. And I think it was that experience that has really connected me with this work around addressing stigma and discrimination. And having experienced that sense of self-stigma or shame, and feeling like, this was an experience that I had to hide, I've become really interested in how we create a community where that's not the case for people, where people can reach out for help and support from the people around them, from professionals, if that's what they'd like to do, so that everyone can experience really good mental health and wellbeing.
Yeah, I have so many more questions about that, but I'll stick to the script for now.
Sure.
I suppose, if you look through your CV, Michelle, there's this really clear thread focusing on young people in particular. I mean, you've completed your PhD in youth mental health, the Young and Well CRC, the Butterfly Foundation. Why young people? Why focus on young people?
Yeah, look, I think, to be perfectly honest, it was because I was young myself doing this work. So, I started volunteering with Reach Out when I was 17, and went on to kind of work at Reach Out in my mid-20s, and then kind of for the 10 years after that was working at Reach Out, and then Young and Well. And so I feel like, in a way, my career has followed my own personal trajectory. As I moved into working with the Butterfly Foundation, it was a bit of a kind of journey into my own kind of early 30s. Eating disorders do affect people of all ages. Some of the growing numbers of people experiencing eating disorders are older women. And so, in many ways, then moving across to SANE and working at the Anne Deveson Research Centre was about following the cohort of people that I'd worked alongside for a really long time, and kind of reflective of me making sense of some of my own experiences along the way.
You mentioned just now, obviously your lived experience with mental ill health, and obviously
Yeah.
that's affected some of the choices that you've made just practically in terms of how you've chosen, what roles you've chosen to take in the course you've chosen through your career. But in terms of your approach as a practitioner, I think I'm interested to know how it's affected that side of things as well, how it changes how you work, having had that lived experience.
Definitely. I think having a lived experience of mental ill health certainly gives you a sense of empathy for the experiences that others are going through. It definitely gives you firsthand insights into how people might navigate their way to help and support, and some of the other issues that they might face along the way. So I'd like to think that it does make me more attuned to some of the issues that people might be experiencing. But it's also something that has enabled me to develop a bit of a sense of a reflective approach to the work that I do. So one of the things that I think is really important for me to remember is that I have a particular lived experience. It's not necessarily reflective of everybody's lived experience. So I work a lot with people who have been incredibly hurt and traumatized by their experience of seeking help and support, people who sometimes have been subject to really coercive practices in the mental health system. That's not my lived experience. I was really privileged to be able to navigate my way to an amazing support group for women who were experiencing eating disorders, that was led by an incredible dietitian and an incredible psychotherapist who had her own lived experience. And unfortunately, not everybody has an experience as positive as mine. So it's really important for me to also be really curious about the experiences that other people are having, and to not assume that because accessing help and support was easy in some ways for me, that it's not incredibly difficult for others. Or alternatively, because I experienced a great deal of self-stigma or shame about my experience, that is necessarily what everyone else experiences as well. So it's important to kind of keep that in mind.
Yeah, and hopefully that experience of self-stigma is one that is kind of diminishing as we kind of get better at this. Okay. So more recently, your work has focused on mental health stigma and discrimination in a more narrow way. That's been the real focus as the director of the Anne Devison Research Centre and the Deputy CEO of SANE Australia. You were part of the team who delivered the inaugural National Stigma Report Card in 2020. Now tell us, just for the totally uninitiated, what is this report card and what's the idea behind it?
Yeah, I might even take a step slightly further back and start with talking about Anne and Anne's story. So for those who never had the opportunity to meet Anne Devison, Anne was an incredible advocate for people who are experiencing mental ill health and their families. She was also a formidable journalist and activist. So Anne was one of the first women in Australia to have a radio program on commercial radio. And she spent most of her career trying to tell the stories of those most vulnerable in the community. Anne, alongside Marg Leggett, was one of the co-founders of the Schizophrenia Australia Foundation, which eventually became SANE Australia. And I guess the reason for sharing that about Anne is that it was very much Anne's legacy that we were trying to honour in the work that we did through the National Stigma Report Card. And what we wanted to do was find a way to understand more about people's lived experience of stigma and discrimination to be able to advocate for change. So what we were hearing from people was that despite the enormous advances that Australia's made over the last 20 years or so, in terms of being more open to talking about mental health problems and supporting people, particularly living with anxiety and depression, for people who might have been experiencing more complex mental health difficulties, the kinds of experiences that Anne's son Jonathan lived with in his life, stigma and discrimination was still very much part of people's day-to-day experiences. And so we set about doing a national survey to try and understand these experiences. So we surveyed just under 2,000 people who were experiencing complex mental health issues or had complex mental health needs. And we asked them about how stigma and discrimination affected their lives. And then we used those insights, which we kind of gathered alongside folks who had their own lived experience of mental ill health, to really try and advocate for change. So we launched the first report card back in November or October of last year. And alongside it launched a series of policy recommendations to really try and put the mental health needs of folks with complex mental health issues on the agenda, and to ensure that there was some really positive action taken to reduce stigma and discrimination.
And just quickly, if there's like a handy definition when we say complex, what are we talking about there above and beyond the kind of anxiety, depression family that you're talking about before?
Yeah, so complex mental health issues are those that have a really significant impact on people's day-to-day experiences. So it might be things like psychosis or schizophrenia, bipolar disorder, personality disorder, but people describe their experiences in a whole range of ways. So some will use those diagnostic labels, some will describe their experience in terms of really significant responses to trauma and other forms of injustice in their lives. So it was kind of an all-encompassing term for all of those experiences.
Okay, all right. And in terms of what you got back from that report card, what did it show you about the relationship between stigma and discrimination? Because they are linked, and I'm interested to know just how closely linked. Is, for example, discrimination the inevitable outcome of stigma? What did you find?
Yeah, so they're difficult concepts to define, but probably the easiest way to think about it is that stigma is the attitudes that people might hold, the beliefs that people might hold about people who experience mental ill health, and discrimination is the behaviour that results from that. There are slight differences. So discrimination, for example, is illegal behaviour, and there are a whole range of behaviours that people do experience that are not necessarily illegal, but are still discriminatory in nature. But effectively, there is a really close relationship between stigmatising attitudes and beliefs and then discriminatory behaviour and how that might impact people's lives.
Okay, so an incredibly close relationship. And I suppose you would have surmised that before you put this report card together, and I imagine part of your goals were showing people in a data-driven way what you kind of already knew. But in conducting this survey, was there anything that you kind of took away from it that made you go, wow, I didn't understand that? Or was there anything that fell into that category for you?
Yeah, probably the most significant finding, which now that I think about it makes so much sense, but surprised me at the time, was that when we asked people about the areas in their life in which they had been most impacted by stigma and discrimination, they talked about their interpersonal relationships, so their relationships with the people closest to them in their lives. And that really surprised me, because I thought that perhaps when people have close relationships with people in their life, that's also where they garner the most support. But when we sort of unpacked that a little bit further, we realized that there are so many different kinds of relationships that people have in their lives. So people talk to us about relationships with extended family who didn't necessarily understand their experience, people's relationships with people in their broader friendship groups, people's dating experiences. So people grappled with when to share with a new partner that they were experiencing a mental health issue and when to keep that to themselves. People had had experiences of feeling like they couldn't share that information, or experiences of being treated really negatively when they did. So for me, that really highlighted the complexity of the relationships that we have in our lives, and how important it is that we build a community that's really supportive of people who might encounter mental ill health at some point in their life.
Yeah, it's so interesting because I think the conventional wisdom is that, you know, if you get to know someone who's experiencing mental ill health, particularly of a complex nature, that's the solve. But it's not that inner ring; it's kind of the next ring out that can be a real danger. Okay.
Yeah, and I guess I was paying more attention to the kind of more structural things. I was interested in employment and housing and the legal system, and there are absolutely huge issues in those spaces. But it was the findings around interpersonal relationships, I think, that struck me the most.
Well, that leads so beautifully into the next set of questions I want to ask you, which is about your current role. You're kind of in this extraordinary position now, and you have this amazing opportunity. In April, you were appointed as the special advisor to the National Mental Health Commission, with a very particular role, which we'll come to in a second. But for those of us who are not familiar with the Commission's work, maybe you can give us a bit of a primer first on what it is that the Commission does.
Yeah, absolutely. So the role of the National Mental Health Commission is to provide evidence and advice on how to improve our mental health and suicide prevention systems. So the Commission really has a role to play in catalysing change to help Australia improve the way in which it supports people who might encounter mental ill health, but also to promote good mental health and wellbeing in the community. We are an executive agency of the Department of Health, but we have a role to play in providing independent reports and advice. So we sit independent of the department in that respect.
Okay. All right. So it's a pretty broad mandate by the sounds of things. But you have this incredibly particular role. You're leading the development of the National Stigma and Discrimination Reduction Strategy, which was a key recommendation of the Productivity Commission report into mental health. And the Productivity Commission is rarely wrong, as we've learned over the years. So this is an extraordinary position to be in. What's that work like, and where is it currently up to? I know it's a big question, so take your time.
Definitely. So it is a really amazing opportunity, and I'm really grateful for the opportunity to work alongside so many really clever and really caring people on this work. It is quite bold and ambitious, I guess, to create a national strategy that looks to reduce stigma and discrimination. But it's a really important opportunity in the context of all of the mental health reform that is going on at the moment. I think the commitment from National Cabinet to resource the development of this strategy was the first commitment of resourcing in response to that Productivity Commission report. And I think that signals just how important it is to reduce stigma and discrimination so that those other reforms can be successful. So we can provide really amazing, person-centered, holistic care to people in the community, and from a kind of health or a mental health systems perspective. But if we're not also creating a community that values and respects people who experience mental ill health, if we're not also addressing the barriers that people might face in accessing social services or justice or broader economic participation, we're not actually going to meet some of those goals in supporting people's recovery. So it is a really important piece of work. So we're about 8 months into the development of the strategy at the moment, and we've really started by making sure that we've got the right people around the table to help us to develop this strategy. We think that lived experience leadership is really critical. And we've established a steering committee that has people with lived experience working alongside people who bring other forms of expertise. And they've worked with us to develop up a series of workshops, which we've actually been holding over the last 3 weeks. So we're 5 workshops in with 1 workshop to go. And we've had people with lived experience of mental ill health or distress, families, friends and allies, and others working in these settings where we're trying to create change, coming together to really reflect on where the opportunities for improvement might be, and to start to explore what some of the actions are. And they've been really amazing sessions to just get an understanding of what's going on for people. You know, a lot of the things are reflective of what we found in the same report card, but at the same time, we've been able to drill a little bit further into some of the structural issues that might be going on for people and how we can address those. So our big job for the next couple of months is going to be drafting the strategy before we then take it out for consultation, and hopefully by the end of next year we'll have a really robust strategy that looks to tackle self-stigma, public stigma, and those really important structural issues as well.
Yeah, it's a massive task, and it's extraordinary to hear that you've already kind of managed to get some insight from those workshops as to where the focus areas should be structurally. Are you in a position to kind of talk about the specifics of that, or is it the kind of work that needs to be worked over more thoroughly before you can kind of?
Yeah, so I guess what I can sort of share is that we're looking to tackle the kind of 3 key forms of stigma that people might encounter. So we recognise that there are relationships between the way that the general public feel towards people who might be experiencing mental ill health, how people feel about themselves when they encounter a mental health problem, and then the way our systems and our institutions behave towards people who experience these problems. So the kinds of laws, policies and practices that these institutions take on. And so we've been having some really interesting conversations about trying to understand exactly what it is that drives stigma in these situations. So, for example, around self-stigma, we've been really wrestling with this idea of, is self-stigma always internalized from people's understanding of public stigma? So the kind of research evidence around self-stigma generally says that it occurs when people become aware that people in the general community hold stigmatizing attitudes towards people with their experience, and people then take that on and feel that way about themselves. Some people have challenged us to think differently about that. So to think about whether or not feelings of shame might arise for other reasons. And I guess how we make sense of that then starts to guide the kinds of actions that might be effective. So do you tackle self-stigma by changing public attitudes, or do you tackle it through other mechanisms? And so that's something that's been particularly interesting for us to start to dig into.
Do you have a sense of which one you're going to go? Or?
Yeah, I don't. And I guess one of the things about doing this work has been just navigating the complexity of all of these things. So, you know, I've been talking a lot about the idea of kind of navigating polarities in in these conversations because there's rarely a kind of clear position. It's more about where we put our energy and our effort and how we make sense of a range of experiences that people might be having. So in my head, I'm kind of imagining a strategy that has a couple of dimensions to it and might have actions that focus on reducing particular types of stigma towards particular types of experiences in particular contexts. Because the way that we destigmatize eating disorders amongst the health profession, for example, is quite different to how we might change the way that the media reports on issues around violence and mental ill health. So they're different strategies, different contexts, different experiences, and we kind of need to get to the nuance of that.
Yes, yeah, no, absolutely. I think that's why I laughed a little bit, because it's like I'm forcing you to a ridiculous binary, and they're absolutely the enemy of good conversation. But yes, so look, I want to talk about the media in a moment. But I suppose as if you needed reminding of the stakes, perhaps the rest of us do. But I guess I wondered if you had any insight into what the longer term implications were for individuals and I guess the community at large and the systems we all share if mental health stigma and discrimination isn't addressed in a meaningful way in the way that you're kind of seeking to do in your current work.
So I think ultimately, if we don't tackle stigma and discrimination head on at an individual level, people aren't able to live the lives that they want to lead. And people end up living their lives experiencing a great deal of shame, not being able to participate fully in the life of the community. But we also lose the amazing contributions that people with lived experience of mental ill health can make to our families, to our workplaces, to our communities, and to public life. And so we really need to get to a place where we are able to remove these barriers that people continue to face. One of the things that sometimes frustrates me about work in stigma and discrimination is that we can go back and read the report that Brian Burdekin wrote in 1993 for the Australian Human Rights Commission on the human rights of people experiencing mental ill health in Australia. And he could have written it today. The kinds of barriers that people articulated, the kinds of experiences that people were having don't seem to have shifted dramatically, even though as a community we're far more open about experiences of mental ill health, and in many ways we've made lots of gains. And I think we've got a really important opportunity here, alongside all of the other mental health and suicide prevention reform that's happening in Australia at the moment, to really tackle this issue and to build a community that respects and values people who have an experience of mental ill health or distress.
Well, there are, I suppose, a lot of people watching today, and just as individuals, and I know that you're sort of principally concerned with big systems. I mean, you're essentially looking at a national strategy. So, but on an individual level, what are the steps that people can take to reduce mental health stigma and discrimination in their lives and in the organisations that they're responsible for and participate in?
Yeah, it's a really great question. And a colleague of mine and I were joking the other day that sometimes this strategy feels like the just be kind strategy. That, in many ways, it's actually about being kind and being compassionate to people, regardless of what their experience might be. But I guess more broadly, it's about not making assumptions about a person's experience because they share that they might be facing a mental health problem, listening to people's lived experience and to their needs and what they're looking for in terms of support, and being reflective about some of our own unconscious biases that we bring. I think one of the really big ones in this space is an assumption that because someone might be experiencing a mental health problem, that they don't have the capacity to make decisions about their own lives or be clear about what it is that they need from others. And I think, reflecting really carefully about how we really feel about these kinds of experiences can be really helpful. Apologize when we get it wrong. We're not perfect as human beings. So, if we have made an assumption or jumped to a conclusion or done something that's unhelpful, say sorry, apologize, and speak out if we see someone else being treated unfairly. I think it's incumbent on all of us to take responsibility for addressing stigma and discrimination.
Where does the media fit in here when it comes to stigma in particular? I suppose we know that representation, positive portrayals have always been really influential in a whole range of areas, whether that's race, disability, gender, and I imagine mental health is no different. Where are we at with this, do you think, in 2021? How far has the media come in terms of positive representation, and what's the distance yet to go?
Yeah, so the media has come a long way. And Australia was one of the first countries around the world to introduce media guidelines around reporting of mental ill health and suicide. So we've got the Mindframe guidelines that are a really fantastic resource for journalists. I think there still is a long way to go, and we do still see really stigmatizing representations of people, particularly who have complex mental health needs, where the media might draw an inappropriate relationship between violence and mental ill health, for example, which contributes to myths around dangerousness or unpredictability. I think, though, we have even further to go when it comes to just being able to convey in our public narrative how diverse people's experiences of mental ill health are, and also being able to talk about mental health in a way that acknowledges the really complex social factors that might contribute to a person's experience of distress or mental ill health. I think for a while, a lot of our public communications around mental ill health focused on medicalizing the problems people might have been experiencing, when it's really important for us to acknowledge the really important role that things like trauma might play in informing a person's experience of distress or of mental ill health. So there's still an opportunity, I think, for us to broaden the types of stories that we're telling, the way that we're telling them, and to really be creative about how we tell those stories. So I think we are starting to see more documentaries around mental ill health. We're starting to see a range of drama programs that have characters who might be experiencing mental ill health, and they're all really important. But then every time we have a particularly negative portrayal, it just takes us a few steps back, and we really, really need to get on top of that one.
Michelle, we were in the midst of, you were in the midst of reflecting on the extraordinary impact that the pandemic has had on the mental health of Australians. And I guess picking up from there, if there is an upside to that, it's that COVID-19 has really put mental health at the forefront of the public conversation, and also government action and investment, especially for children and young people. What has it meant, though, in contrast, I suppose, for people who were already living with complex mental health issues?
Yeah. So I think one of the, I guess, positives, if you can put it in those terms of the pandemic, has been that so many of us have experienced a really tough couple of years. And a lot of people have encountered mental health problems for the first time. And so, in a way, that's created a bit of a sense of empathy for others who might be having some of these experiences. I think, though, what it has done in some situations is amplify some of the experiences that people were having if they already had quite complex mental health needs, and some of the barriers that people may have faced around accessing care and support may have intensified. And I'm thinking, particularly of folks for whom um, they weren't able to necessarily transition to using online services, or telehealth services weren't quite the right fit for them and for their needs. So I think going forward, what we really need to do is ensure that the things that have been beneficial over these last 2 years remain in place to support people, but also that we ensure that those people who did do it really tough and may have had their experiences amplified have the right care and support in the community.
Does it feel like a lasting watershed moment to you that we've really kind of grown in our understanding of mental health challenges as a community?
I think it's definitely put it front of mind for a lot of people. And, for the first time, we've had kind of daily public conversations about the mental health and wellbeing of the community. So it's really important that we continue to have these conversations about the importance of our mental health and wellbeing, and of providing support to those in the community who might need it.
We do often hear about mental health as the long tail of the pandemic, and how young people have been disproportionately affected. What do you see as the critical areas for young people's mental health as we do emerge from the most acute phase of this pandemic? And what do you think is needed to address those critical areas in the long term?
So we know that early intervention is key. If young people are supported to experience good mental health and wellbeing during adolescence, and for those young people who do encounter a mental health problem, they're provided with the right care and support, there's no reason why mental health problems will remain an ongoing feature of their lives. It is perfectly possible for us to provide support early, and for young people to go on to live very happy, fulfilling lives. And so it's really important that we provide those supports to young people now. And when I say support, I don't necessarily mean clinical care. It's about peer support. It's about support within our families and our communities to make sure that young people have the best possible opportunities to take care of their mental health and wellbeing. And that for those young people who do develop quite significant mental health problems, that they can get early access to care and support so that they have the best opportunities in the future.
Okay, so early intervention is the big one by the sounds of things.
Absolutely.
Yeah, so we, I'm kind of getting to the end of the list of questions that I was hoping to get through before we sort of through to the audience. But I guess there's just a few questions really about the trajectory for the national strategy that you've been working on, and also your own career. So you are due to deliver the national strategy at the end of 2022 with a 3 to 5 year timeline for implementation. They're quite long time frames. Anyone who's worked on projects like that knows how difficult it can be to measure success over that long period. How will you define the success of that strategy at the end of the 3 to 5 year period, do you think?
Yeah, I guess I'm really lucky that I'm surrounded by some pretty smart people who are going to help us work that out. But I think for me, it would be about at the end of the five years, if that's however long the period is, that we have taken some really concrete steps to address some of the structural barriers to participation and inclusion for people who might be experiencing mental health problems. I think measuring longer term cultural change, so attitudinal change, is really difficult to do and really difficult to see in the data. Usually you wouldn't kind of see those sorts of really big shifts in the community for a kind of 10-year period or so. So what we can measure though is how successful we've been in creating some of those changes to systems, to processes, and to kind of immediate outcomes so that people are able to participate more fully in their community, feel more connected and valued by their community, and get access to the kind of care and support they need, whatever that care and support looks like for them.
So is it, when you say concrete, do you mean like actual sort of like hard numbers, like benchmarks around participation, say in arenas such as the workplace, or are there any others that I'm kind of missing?
Yeah. So really good example is Australia currently has a relatively low employment participation rate for folks who experience mental ill health and other forms of disability. And so if we could see some real shifts in people participating in the workforce, in people feeling supported by the workforce and feeling like they can get access to the kinds of reasonable adjustments that might be necessary to participate fully in their workplace and to contribute, then I think we'd be doing a really fantastic job.
We mentioned right at the beginning of the initial interview that your role obviously brings together study that you've done in a number of disciplines. You did undergraduate studies in psychology and in political science. What advice would you give to any young graduates watching who are considering, I guess, not only navigating the health and medical world in a narrow way, but exploring careers that intersect a number of disciplines in the way that yours has?
Yeah, it's a really great question. And, I didn't start out wanting to necessarily work in policy, but it was something that I found I really loved along the way. And I guess my piece of advice would be to be open to having lots of different experiences in your career, trying different things out, volunteering, putting yourself forward to participate in the kinds of public lectures that are offered by the university, or opportunities to talk to people from disciplines that are not your own. I had an opportunity a couple of years ago to be a delegate in the Australian American Young Leadership Dialogue, and I was one of the very few people who came from a health sector background. Most of the participants worked in, politics, but particularly around geopolitical or strategic issues. So people who worked in the military, people who worked in kind of technology companies. And probably one of the most powerful aspects of that experience was getting to talk to people who were in completely different disciplines to my own. So I walked into my first event with the dialogue and was seated next to the person who was the chief of the Australian Air Force at the time. I know nothing about the military or about the Air Force. I didn't know who this man was, except that he was wearing a uniform. And what I actually found from that conversation, after I kind of got over my initial I know nothing kind of perspective, was that actually there were lots of lessons about leadership in the military that apply to leadership in the health sector and apply to leadership in public life. And so being able to find that common ground with the perspectives of people from different disciplines and different backgrounds, I think is an incredibly valuable experience to have, and means that you can kind of traverse those different sectors and different disciplines really well.
Yeah, I think saying yes to opportunities and being curious it's such simple advice, but it really is very good advice.
Yeah, absolutely.
So I guess I'm aware that we've just spoken about how you have this quite long long-running task in front of you, this big task in front of you. So in some ways, this is an unfair question, but do you know what's next? I guess, what are your ambitions after looking beyond this strategy?
Yeah, it's a really good question, and it's something I've had the opportunity to think about a lot over the last year or so. And, I used to be someone who kind of had a really clear goal for the next type of job that I wanted to do, or the next kind of organization I wanted to work in. And I guess, leaving the last organization I was in and joining the team at the Commission has probably taught me that it's not so much about the job or the organization or even the kind of thing that you're doing, but it's more about how you show up as a leader in those places. So I don't know whether I've necessarily got an ambition to do a particular thing, but I guess a bit of an ambition around being someone who brings people together to solve really tricky problems, that draws on people's strengths and their experiences, and provides a really supportive environment where people can be themselves and bring their whole self to work. So I think, as long as I'm able to do that, I think I'd be really happy in the next step in my career.
I love the idea of bringing your whole self to work.
Yeah, it's so important, and particularly when we talk about tackling mental health and stigma in the workplace, the more we can create environments where people feel safe and people can bring their whole self to work, whether that is an experience of mental ill health or whether it's about bringing their cultural identity or another aspect of who they are, I think the stronger our workplaces and our communities become.
We have some really great questions that came through from the audience. Thank you to everyone who sent those in. Some of them I was going, oh, I should have asked this. So I'll start with, it's a great question. So noting that institutional/systemic destigmatization will require a unified approach from all areas of government, for example, social services, health services, employment services, etc. What do you see as the main barriers to addressing this issue from a whole of government perspective? And how would you suggest that policymakers address this?
Yeah, it's a really good question. And I think the biggest barrier is just how complex this area is. And, as the person asking this question noted, there are so many aspects of government services, but also community services that impact people's lives when you might be experiencing a mental health problem. I think we're really lucky with this piece of work that it's something that has the support of the National Cabinet process, and that gives us a mechanism to really be able to connect with the states and territories who have responsibility for delivering a lot of these kinds of services on the ground. But we've also put a lot of effort into connecting with different stakeholders, so community service providers and people working in systems and institutions to understand where the levers for change might be, so that we can hopefully tackle some of those in a really meaningful way. So not underestimating how big this challenge is, but I think there's some good foundation pieces there.
Okay, so seeing the size of it and collaboration seems to be the main way that you'd get past that.
Yeah,
yeah,
absolutely.
Okay. Another question from the audience. I was wondering whether the strategy will also take intersectionality into account in addressing issues that occur for people at the intersection of various marginalized identities and their experiences of mental ill health.
Yes, it will. So we've actually developed up a set of guiding principles for the strategy. And the fourth principle speaks exactly to that. So it's around respect for and understanding of culture, identity, and intersectionality. And, we know that sometimes people develop distress or mental health problems as a result of experiencing other forms of stigma and discrimination, whether that's homophobia or transphobia, whether it's racism or other forms of discrimination. We also know that if a person is experiencing mental ill health and they're met with a response that is discriminatory on the grounds of race or gender or any other factor in their identity, that can also really amplify the experience of stigma that they might have around mental ill health. So it's an incredibly complex relationship, and it's really difficult to sometimes tease out exactly what's a result of stigma around mental ill health and what is a result of other forms of stigma and discrimination. So it's really important that whatever actions we're developing take into account the whole person and all of the experiences that they might be having.
I guess more specifically, there was another question that was, I guess, related to this. It was specifically about LGBTQIA plus community, and there being a very difficult history there with the psychological profession.
Yeah.
And the questioner lists here the example that, the WHO, which I didn't realize that it happened quite this late, didn't remove homosexuality from their list of illnesses and diseases until 1992. And continues to make asexual people feel pathologized as sex aversion disorder. So there are still some really thorny issues there for that community. What's the path? What's the solve for that? What's being done to address that problem?
Yeah, so what we know about reducing stigma and discrimination is that it's really important to take into account all of the psychosocial factors that are impacting on a person's experience. And this idea of kind of pathologizing who someone is and the experiences that they have can be incredibly unhelpful, and particularly the LGBTIQ plus community is really harmful in the way that medical labels have been used to pathologize and discriminate against people around their identity. So, those kinds of issues certainly are really critical to address more broadly. And then I think in terms of the work that we're doing to address stigma and discrimination, it's about us recognizing how harmful and how hurtful some of these experiences have been for people, and recognizing that then might lead people to fear that they will be treated poorly if they do engage with a psychologist or a psychiatrist or a medical professional of some kind. So it's about being really attuned to the impact that trauma may have had, and really ensuring that there are really trusting and open and authentic relationships there between health service providers and between the community.
There's a question here which I guess goes to what we were talking before about the sheer scale and the sort of siloed nature of all the various parts that we need to engage in order to achieve what it is you're trying to achieve. This person's asked, in seeking mental health support for my teens, it's become clear that a lot of change needs to happen in both the health and education sectors. Genuine, skilled, collaborative practices seem to be at the base of how any changes happen. So very much to the point you were making.
Yeah.
Is there already good work happening in the mental health realm to promote collaborative practices? So I guess a specific question about how, the specifics of how that, if that collaborative approach is coming along.
Yeah, so I guess there's a couple of examples where collaboration is really key. So some of that is between organisations in terms of the kind of work that they might be doing together, but it also happens very much at a kind of individual level and with the person's community. There's a really interesting approach that I've learned a little bit about in the last couple of years called open dialogue, which there's a couple of different ways of facilitating open dialogue, but it's really about putting the person with the lived experience at the centre and understanding all of the relationships that person has, the needs of the people in those relationships and working to help to address those to bring about better outcomes. And it's sometimes a process that is facilitated by a peer worker. Sometimes it's facilitated by a health professional. It depends on the kind of philosophical approach people are bringing to the table. But what it kind of enables is for people to understand who supports that person and what role they might play in supporting that person's well-being over time. So you can kind of do that sort of thing at an individual and community level, but then there's also the bigger picture. How do we get, you know, health services to talk better to the education system, to talk better to the child protection system, wherever those kind of relationships need to happen? That's probably the trickier part.
Yeah, I'd say so.
Yeah.
And a question here, which I really liked. As a person working in a lived experience mental health disability care organisation, there has been a long-standing difficulty that people stick to their original training as opposed to following along with the developments of care. And this is a problem in every field, I suppose.
Yeah.
The focus towards evidence-based care has helped to break that funk as it relates to care, but it's often noticed that old, outdated, and stigma-driven cultures remain and can cause harm to people within companies who have lived experience. Are there any recommendations you can make as to how we can positively influence change to outdated culture?
Yeah. So changing culture is really, really difficult. But I think what's really essential in creating good cultures is that there's a shared set of values that people really buy into, and a culture where if those values aren't being adhered to or really lived, that people feel psychologically safe enough to be able to call out when those values aren't being lived. And I think that's a really difficult thing to do in organizations, but it starts with people modeling that it's okay to make mistakes as long as you're committed to improving, and that, you know, it's okay to say that you don't have all of the answers. And I think sometimes our professions are geared towards having all of the answers. You know, people have often perceived doctors as the ones with the answers. And really, it's about doctors or medical professionals bringing their knowledge to the table to marry up with the knowledge of the individual about their own circumstances and what's going on for them, and the insights of other professionals who might be able to help that particular person or that family in that situation. I think it's also really important that we start to embrace a diversity of views within organisations and within cultures. And I saw a really great presentation a few months ago, and I'm not going to do it justice, but it sort of talked about what might happen when you bring new people and new ideas into an organisation. And I thought particularly about people who might be coming in as a peer worker with a lived experience. And it sort of said that often what happens is when someone comes into an organisation with that kind of new skill and experience, we expect them to assimilate into the organisational culture. But actually, if we're about creating change, the organisational culture and ways of working needs to expand to incorporate that new person, their new perspectives and what they bring. Otherwise, we're only ever going to be working with that kind of existing original culture rather than kind of broadening out to include those perspectives of others. They talked about it in terms of people who might come from different cultural backgrounds or different, from different disciplines, kind of injecting new ideas into a workplace. And I think that's a really important thing for us to bear in mind as we bring in more peer workers, more people from allied and related disciplines, different ways of understanding. Hopefully our cultures will expand to include those different perspectives as well.
Michelle, thank you so much for your time and for coming back to answer more questions.
No problem.
After your internet was brought down by Melbourne's weather. Thank you for your generosity. We wish you all the very best with the national strategy and what's to come.
No problem. Thanks so much, Ange.
But yes, thank you for attending the final Alumni Hour event for the year, and have an excellent evening.